All right. Well, thank you so much to everybody that's joined us and that will watch this back at a later date. My name is Allie, and I'm lucky enough to serve on the board of Project Lyme. If this is your first time hearing about Project Lyme, we are a 501c3 nonprofit that exists to educate and assist. Project Lyme's mission is to eradicate the epidemic of Lyme disease and other tick-borne illnesses by spreading awareness, providing educational resources, funding peer-reviewed research, and supporting advocacy that hopefully will help to end some of the suffering that you and I have both experienced in our lifetime. Since 2016, Project Lyme has challenged the misinformation about diagnosis and treatment, advocated for patient rights, and built a community for Lyme patients as well as their loved ones. If your Lyme and tick-borne experience was anything like mine due to inaccurate testing for Lyme and co-infections, I had a delayed diagnosis of 2 years, leading to permanent physical damage, permanent neurological damage that unfortunately will, unless hopefully there will be a scientific advancement in the future, but that probably won't change for me. And this is why we need new groundbreaking tests that are accessible to all and accurate so that other people do not have to suffer the way that I did and the way that you probably did. I do want to mention just before I forget, if you have a question for Nicole, who I'm going to intro after this, please leave it in the Q&A function. And at the end of the presentation, we will take some limited questions and hopefully get you some information you need. So Nicole, thank you for being with us. Nicole Bell is an author, entrepreneur, and advocate for tick-borne and neurodegenerative diseases. Her memoir, What Lurks in the Woods, detailed her husband's harrowing experience with misdiagnosed tick-borne illness and seeks to help others navigate chronic conditions. Originally from Boston, Nicole earned a bachelor's and master's of science in materials science and engineering from MIT and a master's of science in biomedical engineering from Duke University. Nicole is currently the CEO of Galaxy Diagnostics, where she combines her professional experience with her passion to change the tick-borne disease landscape. Galaxy's mission is to create a new diagnostic standard of care for tick-borne diseases and save millions of people from descending into chronic illness. So Nicole, thank you for everything you do, and I will turn it over to you.
Great. Thank you, Allie, and thanks everyone who's here today. I'm going to share my screen and go into presentation mode. Allie, if you can just confirm you can see okay? Great. Okay, so today, we're going to talk about diagnostics, which are a critical part of the challenge that we see in tick-borne disease. And hopefully by the end of the presentation, I want you all to have a better understanding of this statement. So you've probably heard this in various, conversations, social media, et cetera, that Lyme disease testing is about as accurate as a coin flip. And so I want to really dig into the whys behind that statement. So why is Lyme so challenging? What are the limitations of current testing methods? And then most importantly, how can we do better? So in terms of the outline of what we'll go through, so first, just really talk about the current state of vector-borne disease. And I want to talk about not just tick-borne disease, but vector-borne disease. Vectors are kind of biting insects that can spread disease. And I think it's really bigger than just ticks. It's all sorts of different biting vectors like fleas and lice and sandflies, all sorts of other things can spread some of these infections. Then we'll talk about the types of testing and what that means from a technical standpoint, break it down by pathogens, and I'm going to focus on the big three, the three Bs, Borrelia, Bartonella, and Babesia, and then talk about the how can we do better, and specifically on advancing direct detection. So first, just in terms of where we are today, and I think a lot of the people on this webinar probably they're living this, so you don't really have to get an explanation or a slide on it. But when I explain this to people that are outside the field, I actually to just imagine that you have a set of pathogens that grow slowly, they evade the immune system, they can cause really complex, confusing symptoms across multiple body systems, and they're linked to complex chronic illnesses that cost over $60 billion globally, right? So it's a big problem. And then I want you to imagine that the standard of care diagnostics for one of these top, issues and disease states is only 50% accurate. And that you can get one of these pathogens with a single tick bite, a cat scratch, or a flea infestation. And when you frame it that way for people outside the field, it seems unreal and completely unfeasible that would be where we are. But unfortunately, that's exactly the situation where we are with tick-borne diseases and vector-borne diseases. And so, that 50%, that coin flip analogy, I think that's a good analogy, but what's the science behind that? Because there's multiple studies that have shown time and time again that the standard two-tier test and even the improvements made in the modified two-tier test are just not accurate enough. And so here's a compilation of references. It's really in these studies between 30 or 39 and 58, so 40 to 60%. I've seen other studies where, accuracy is as low as 30%. So this is the reality. And we'll talk about why this is and why the current technology isn't sufficient for accurately diagnosed disease. And unfortunately, rash-based diagnosis is even worse, right? Or about the same, actually. And this is an analysis. One of the resources that I would point people towards is the Center for Lyme Action State of Lyme Disease Research. This is actually a project that I worked on with CLA before I joined Galaxy. And as part of that, we looked at the research, summarized it to help lobby for more funding in the space. And as part of that, we looked at rash analysis because it hadn't been really put together what the impact is. And so we combined a series of studies looking at, what's the presentation rates of certain types of rashes? What are the misdiagnosis rates of those rashes? And when you put all that together, what's the potential that you're going to get an accurate diagnosis based upon rash? Because if you don't have an accurate test, then people are going on clinical symptoms, and rash is a big one. And it turns out that it's about 50% accurate as well. So again, another coin flip as to whether or not you're going to get a correct diagnosis based upon those, the early rash presentation. And that's because most people do not get the typical bullseye. It's only about 14%. Some people don't get any rash at all, about 30% of people. And so there's a lot of inaccuracies that can occur with just looking at that presentation. And then the last thing, which again, a lot of people, here really know, is it's not just about Lyme, right? Lyme rarely comes alone, and it's commonly coming along with some of these top co-infections. And if you look at the LymeDisease.org data, over 50% of chronic Lyme patients have one or more co-infections, and over 30% have two or more co-infections. And so, you can get these pathogens along with Lyme, you can get these pathogens without having Lyme. And so, I actually sometimes don't like the term co-infection because it implies that they have to come together, and they can often be on their own or in combinations that don't include Lyme disease. And so a lot of clinicians are not even screening for these, and some are not even aware that these can lead to complex chronic symptoms. And the impact is huge, right? So these are 3 different case stories of people with completely different presentations. All were misdiagnosed initially and developed into very different phenotypes or presentation of disease. So on the left, some people may know Dr. Neil Spector, who is really big in the Lyme community and advocacy. He had cardiac issues to the point where he ended up getting a pacemaker and a heart transplant because of misdiagnosed Lyme carditis. The story in the middle was my husband. He was misdiagnosed and, given a diagnosis of Alzheimer's disease. As it turned out, he had not only Lyme, but also Borrelia and, or also Bartonella and Babesia. And then on the right is a young boy who was 14 years old and presented with sudden onset psychosis. And as a result, he figured out that the cause of his disease was Bartonellosis, and he had Bartonella. And when he got treated for Bartonella, all of his psychiatric symptoms went away. And so completely different presentations. And unfortunately, if you don't know to test for some of these pathogens, or you use the wrong test for these pathogens, you might not get to the answer. And really, people progress to complex chronic illness when they could have gotten timely treatment and gotten well. And so this is why testing is so important, because the right test at the right time can really change the course of somebody's life. And so I want to start with, what are the types of testing, right? I think we got a little bit of an education of this in COVID. I think people became familiar with terms like PCR and antigen and so forth, but it can still be confusing. And so there's three major categories of testing. First is antibody testing, or sometimes called serology. And here, this is known as an indirect method. And that's because it's not measuring the pathogen itself, it's measuring your immune response to the pathogen. And so it's indirect because it's one step away. It relies upon the host or the person's response to the pathogen. And that adds an extra variable that makes it complicated. Then there's direct testing methods. And this is something, again, in COVID, if you wanted to know if you have COVID, you didn't get an antibody test. You would get either a PCR or an antigen test. And so what are those? So PCR is a method which measures the DNA of the pathogen itself. So you're trying to essentially isolate that DNA and then amplify it and see if that pathogen is present. Or in antigen testing, you're looking for molecules, in the case of what we do, proteins that are actually shed by the pathogen. And so they're proteins that are specific to that pathogen, and then they're shed by the pathogen. So detecting them is evidence that that pathogen is present. And so that's why it's considered a direct method, because there's no intermediary immune system in the loop, as you see with antibody-based testing. And so, well, what test will my doctor order? Well, traditional medicine is almost always going to order the current standard of care, which is either the standard 2-tier or the modified 2-tier. There's also different other types of antibody testing names that you might hear. You might hear ELISA, IFA, Western blot. These are all different ways of measuring antibodies. And there's inherent limitations in antibody testing, which leads to that kind of coin flip analogy. And so I want to break that down as to why some of these challenges exist within the space. So the first limitation for antibody testing is that treatment of early stage disease is the best. One of the things we know about these pathogens is the earlier you diagnose and get treatment, the more likely you are to respond effectively to treatment. And even a 30-day delay in your diagnosis means that you're over 2 times more likely to develop persistent symptoms. And so this is something where early diagnosis is key. The problem with antibody-based testing is that they take weeks to develop. And so you're actually missing some of that window where treatment is most effective. So there's 2 different types of antibodies. The first is IgM. These come first, and they're generally non-specific. So they can be used for diagnosis, but you have to be careful because often they might be cross-reactive with other things. And so you end up potentially getting false positives where, you're getting a positive result, but it might actually be cross-reacting with another organism. And then IgG come later, and those are more specific and better for diagnostic purposes. But again, they take 4 to 6 weeks to reach peak form. And so that's a challenge for getting that early and accurate diagnosis and treatment. The second limitation, and this has been shown in multiple, publications, and actually Dr. Monica Embers at Tulane has done a fantastic job summarizing some of the masterful methods that Borrelia has at evading and suppressing the immune system. It actually actively inhibits your immune system response, inhibiting some of your frontline methods for tackling the disease, modulating your cytokine profiles. It actually spits off antigens to neutralize antibodies. And then it also evades. It changes the surface proteins to help evade the immune system. It swims, literally physically evading, swimming faster than all of your immune cells. And then it also can hide in sites that are considered immune privileged, like the joints and the eyes and the brain, that don't have the same access to all of the different immune cells that help combat the pathogen. And so it's really good at evading the immune system. And so then you can imagine using a measure of that immune system might be challenging. And as a result of that evasion and just the individuality that we all have, the host or the personal response that you might have to a pathogen can be very, very different. And so this is a study, again, done by Monica Embers at Tulane. And this is looking in rhesus monkeys, which is actually a really good, surrogate for humans in Lyme disease testing or Lyme disease studies. And here she infected a whole series of monkeys with the same exact pathogen, and then looked at what was their antibody response. And so here's just two of those monkeys that are called out. And what you can see is over the course of the weeks, each one of those lines is a different antibody response in one, the two different graphs with the two different hosts. And so as you can see, the monkey on the top had some antibody response early, but then later there was almost no antibody response, right? Which is often the case with chronic patients. You might have the pathogen, but you don't test positive. That was the case with my husband and Dr. Neil Spector, the cases I showed earlier. And then the monkey on the bottom actually had high antibody titers. So we're all different and all of our immune systems are going to behave differently. And so this introduces yet another variable into the equation when you're using that as a test methodology. And then the fourth limitation is that antibodies equal exposure, not current infection. And so a lot of people actually will get treatment with the standard course of antibiotics. And at Johns Hopkins University, they showed that up to 40% of people actually remain symptomatic. And about 14% of those people have chronic symptoms. And so we know that they've been infected with Lyme and they've been treated. The question is are they still sick because they have ongoing Borrelia infection in their blood, which is certainly possible and has been shown? Or are they still sick because they have other co-infections that haven't been properly diagnosed? Or are they sick because they have immune dysregulation or mold toxicity or some of the other things that end up becoming important in Lyme cases? And if you're just looking at antibodies, it's hard to tell because you don't know whether the pathogen, the person's been exposed, but you don't know whether it's still actively there. And so having the ability to go directly to measure the pathogen is really important and not capable in antibody-based testing. And so using direct methods, is the pathogen still present, is really the preferred methodology across all infectious disease. But within this space, at least for some of these top pathogens, it's not been available. And so, well, why is that? And one of the things that is important to understand is that these pathogens are considered stealth pathogens, right? And they're different because they hide in tissues, they evade the immune system, and they multiply slowly. And so if you compare the amount of the pathogen in the bloodstream or wherever tissues you're infecting, if you look at some of these acute pathogens that you're testing with PCR, generally it's going to amplify really quickly and get to high levels in the blood so that you can detect it with conventional PCR and conventional next-gen sequencing. But these pathogens don't have that kind of exponential growth. They grow slowly, they evade the immune system, they hide in tissues. And so they're below the limits of detection of conventional techniques like PCR and next-gen sequencing. And as a result, that's why we've been using antibody testing, because we haven't had the ability to actually, get the direct detection of the sensitivity that's been needed. And so breaking it down by pathogen, this is really important because just like we're all different and, our host response is different, these pathogens are all different. And there's a lot of them, right? So here's just a list of the top flea and tick-borne pathogens, the 3Bs, which I've talked about. You also have Ehrlichia, Anaplasma, Rickettsia. And so you have to really consider any of these anytime you get some sort of exposure. And it's even more complicated than just Borrelia. because if you look at the genus, which is kind of the whole group of these bacteria called Borrelia, it actually breaks down and it's a little bit more complicated. So there's certain Borrelias that lead to Lyme disease, like Borrelia burgdorferi or Evzelii or Guerinii in Europe. But there's also certain Borrelias that lead to relapsing fever Borrelia, and those have slightly different behaviors than what you might see in Lyme Borrelia. And what we're learning with emerging research is Babesia is also kind of a similar beast. And we're starting to understand that there's higher abundance Babesias, like Babesia microti, which I think is what a lot of our clinical knowledge in the literature is based upon. But emerging research is showing there's actually very low abundance Babesias that behave differently and don't give the classic air hunger and night sweats, but lead to debilitating symptoms and fatigue and other issues that are leading to complex chronic symptoms. And so it's actually more complicated than just the type of bacteria or parasite. It can be even more specific to what is the species and how is that impacting the overall patient. And so when looking at these different pathogens, it's really important to understand the microbiology. And I don't want to get, too deep in the weeds, but, it's really like, where are these pathogens in the body, right? If you're going to detect them, one of the ways that you have to know is, where do they like to live? Where can we, what samples would we use to give us the best possibility of detection? So Lyme does not like to be in the blood. It hides in tissues. And so one of the things I like to say is, you're more likely to get struck by lightning in your lifetime than you are to find Borrelia in blood with traditional PCR. And it's really just a statistics game. And so it doesn't like to be in the blood. Bartonella actually infects blood cells and the vessels and vasculature, but it cycles in and out of those blood cells on a 7-day cycle. And so you can get it, but it's kind of difficult and can be challenging. Babesia also known to infect blood cells. But again, recent research is showing that it actually can be in really low abundance and potentially below the limits of traditional PCR. And so that's something that is really important to understand, because you might test negative and you might actually still have Babesia on board. Relapsing fever Borrelia. This is very different from Lyme Borrelia, and this actually replicates into high numbers in the bloodstream, particularly during the febrile events when you're having that fever and reaction. Ehrlichia anaplasma, they infect blood cells, so a little bit easier to get with traditional techniques. And then rickettsia actually infects the vascular cells that line our bloodstream. And as those cells get sloughed off into the bloodstream, it becomes more readily detectable with conventional techniques. So what does all that mean? Well, if you're looking at, if I'm going to take a blood sample, what's the likelihood that I'm going to get a direct detection result, or I'm going to be able to find that specific pathogen? And as you can see, it's very different. The color coding, basically for Lyme Borrelia, it's very, very challenging. For relapsing fever, it could be easier if you're having a febrile event, but if you're away from that febrile event, it might be in lower concentrations and you might need advanced techniques in order to get a positive result. Bartonella and Babesia, detectable, but not with standard techniques. You really need advancements and new sensitivity enhancement methodologies in order to get accurate direct detection. And so you really need to think about the techniques and what you're doing and how you're testing, because a test result is only as good as the test that's looking to actually give you that answer. And so I've talked a little bit about direct detection and the challenges that go along with it. And so the question is, well, how do you make it better? How do you actually take these stealth pathogens and get it to the point where PCR testing or antigen testing can be a viable alternative? And frankly, this is what brought me to Galaxy after, on the other side of my husband's journey, which, if you know anything about my story, it didn't end well. My husband ended up passing away because we got diagnosis too late. So on the other end of that journey, I wanted to dive in and help. And I realized that fixing direct detection was really the key. That is going to solve a lot of problems within the space. And if you can get an accurate diagnosis, then you're more likely to get an accurate treatment. And that's what drew me to Galaxy, because that's the problem that they had been working to solve for over a decade in using publication and research-backed science to advance that critical problem. And so, well, how does that happen? How do you kind of get accurate results? Well, for Lyme, again, blood's not a great sample. So what is a great sample? We actually use urine because one of the reasons is that immune defense mechanism that I mentioned earlier, where the bacteria is actually shedding proteins on a regular basis to confuse the immune system. Well, those proteins actually get aggregated into the bladder and excreted in the urine. And researchers at George Mason University, and then eventually series in Galaxy, showed that you can use that for accurate detection. And so that's a very great way to see whether or not, Lyme is present in both the acute and the chronic scenarios. For the blood-based co-infections, so for relapsing fever, Borrelia, Bartonella, and Babesia, actually using a blood-based assay, which uses digital PCR and culture enhancement. And I'll go into a little bit of what that means, but methods to improve the sensitivity to make it so that something that wouldn't be detectable ordinarily by traditional PCR actually can be detected. So first, the urine antigen test for Lyme, as I mentioned, the bacteria spits off these proteins, they congregate and get in the bladder and then get excreted out in the urine. And so we use what's known as a capture and concentrate technology, where we use essentially beads to capture all of the protein in the sample, concentrate it down, and then detect it to show whether or not it's present. And the result in published clinical data is, extreme improvement in performance over the traditional standard of care. So here's looking at a series of acute cases where we're, with the traditional standard of care, again, that coin flip, 50% accurate. The urine antigen test was able to capture and correctly identify and diagnose all of the patients in the study. So huge improvement in performance over traditional methodologies. So I mentioned it's also useful in chronic cases. Here the question is, okay, why is a patient still sick after treatment? As I mentioned, it could be because the patient has Lyme that is still active in the body. It could be because there's a misdiagnosed co-infection. It could be because there's bacterial debris. It could be because there's other issues in immune dysregulation. And so with patients that are still not doing well, we use the urine antigen assay to discern who has an active infection on board. And in a survey of 100 patients, all of them that were showing ongoing issues and symptoms of chronic issues, all 100 of them were antibody negative, right? So not standard two-tier testing, modified two-tier testing, not helpful. And in this study, about 40% of them showed that they still had an active infection. And so it's really useful to tell clinicians and patients when you still have an active case of Lyme and when you might be looking at other things that you might want to be diagnosing and treating. And so switching over to the blood-based detection, so here we're actually measuring the DNA of the pathogen itself. And this is through, most people are familiar with PCR, but as I mentioned, PCR is not sensitive enough. And so what are the elements that we're using to enhance the sensitivity? So first thing is with Bartonella, it cycles in and out of the blood every 7 days. And so this is one of the reasons why, if you look at Galaxy testing, we do multiple blood draws, typically 3 blood draws within a week. We also do culture enhancement, which we have proprietary media which grows up these organisms to higher levels to make them more likely to detect. And then finally, we use an advanced technique called digital PCR, which enhances the detectability of these pathogens. And so, well, what is that? What is digital PCR and why does it matter? And so the analogy I like to use is if you're taking conventional PCR, right, or qPCR, it's like, and you have a low abundance pathogen, it's like trying to find a needle in a haystack, right? You've got one shot to essentially find that needle in that giant haystack. But in digital PCR, what we do is you take that haystack and you separate it into 20,000 different piles. And then you interrogate each one of those piles individually. And so if the needle is in one of those smaller haystacks, you're much more likely to find it. And that's how you get the sensitivity enhancement and the improvement. So it's a very different technique. And it's really been groundbreaking in the research to identify and to show the linkages between these pathogens and complex chronic diseases in patients that were, misdiagnosed, but with this technology saying, hey, this pathogen actually is present, and here's the test results to prove it. And so in terms of performance, here's just some data showing digital PCR performance in Bartonella and Babesia. So on the Bartonella side, if you took a high-risk patient group, so these are actually veterinary workers, because people that have a constant exposure to animals are actually at high risk for Bartonella. And of that patient group, with traditional PCR, only 3 showed that they were positive for Bartonella. But using digital PCR, actually 18 were shown to be positive. So a 6x improvement over traditional methods, right? On the Babesia front, with information that was recently shown at the 2024 ILADS by Dr. Maggi from NC State, he looked at a series of samples that were known to be infected with Babesia. And using traditional methods, it was a really low percentage rate, so 4%, about 4 to 5%. But with digital PCR, that positivity rate went up to 62%, right? So huge improvement with this methodology. And so again, the testing techniques matter. And so, I know I showed a lot of the limitations with indirect detection earlier, but I do want to note that it's still an important methodology, and it's still something that is useful in diagnosis, particularly for Bartonella. And one of the things that we've seen clinically is you can have different presentations of what's going on in the host. So if you have a strong immune response, you may have really high antibody titers. And because you're having a strong immune response, the opportunity to find these live pathogens in the DNA of the pathogen goes down, because your immune system is actually clearing the pathogens from your blood. And so you might have a high antibody titer and a low direct detection, or you're not able to get a positive result in direct detection. Conversely, if you're not having a good immune response, a patient like my husband who's been chronically ill for some time, you're not going to have a lot of antibody titers. That makes it more likely that you're going to get accurate direct detection. And so when possible, we actually recommend, particularly for Bartonella, because that's one of the challenging organisms, we recommend doing both. So we have an IFA for the top 4 species of Bartonella, and look for those, and we put that, which is antibody-based testing, and then we put that in combination with the direct detection to get the best possible diagnosis. So all in all, in terms of overall recommendations, I guess key takeaways is these stealth pathogens are tricky. I think most people on this call probably know that. But one of the things that we're committed to is, you really need a toolkit. Indirect methods are helpful for diagnosis, but they can miss a lot of cases. Direct methods are preferred, and we've got great advancement at Galaxy. But, you need to be careful how you interpret, and you always want to consider the samples and what you're looking at, and how to best diagnose. And so again, when possible, use both. Sample types matter. So urine is great for Lyme disease, and then for other blood-based pathogens, for Bartonella, relapsing fever, Borrelia, and Babesia, blood-based methodologies can be effective with sensitivity improvements. And then there's other things that we didn't really talk about today: the stage of infection, whether you've been on antibiotics, if you've had any recent treatment that might provoke these bugs to come out. Those are also factors, and those are things that we're happy to work with clinicians on to kind of make sure we understand the right time, the right time to use the different tools in the arsenal to figure out and get the best results. So with that, I will open it up for questions.
The other considerations will have to be a part 2 webinar.
Yes.
For any viewers that have questions, feel free to pop them in the Q&A box and we will go through them. Joseph has a comment and a question. They said they're a veterinarian and they also face significant difficulty in making a definitive diagnosis for Lyme disease in their patients. Their problem is that in a number of tests, other spirochetes cross-react with the Borrelia or Dorferi, which I thought was interesting. His question was, are the urine tests true antigen tests or tests for antibodies, or antigen antibody complex testing?
True antigens. So we're looking for the OspA protein, which is a surface protein that is shed by the bacteria, and it's shed pretty consistently across the different Lyme Borrelia species. And then we're looking and measuring the concentration of that protein in the urine.
Very interesting. Hopefully, Joseph, that answered your question. If somebody is interested in asking their doctor about this testing, like, I guess their question, it seems more logistical, like, where do you go for the testing? Is it ever covered by insurance? Like, what does that look like?
Yep. So we have testing available. Providers can go onto our website and set up an account if they're not typically users. We have a fantastic head of clinical sales that will work with any new providers that might not be familiar with our testing, and she'll work with you to make sure that the process goes smoothly. And we do provide super bills to patients. So we'll, give the information and you're welcome to file that. We have CPT codes, and we find that patients do get reimbursed. It really just depends on your health plan. So I can't really say, how it would be for each individual, but we do support in that journey by providing super bills.
Somebody said absolutely amazing presentation. I agree. Their question is, how important are genetics when it comes to testing?
That's a great question. I think in terms of testing, it's especially with direct detection, it's not as much of a factor. I think one of the things that we're still really starting to uncover in the research is how genetics impact people's, progression of disease. I think that's a really complicated and fantastic area of study. Why some people, might have different responses and different immune complexes and up or down regulation of their certain immune cells. And I think there's a lot that we still have to learn there. But one of the things that I like about direct detection is that it's pretty, when you get that positive result, it's proof that the pathogen is there. It's pretty straightforward. And we're doing everything we can to make sure that the sensitivity is the absolute, maximum, so we can maximize the results, if that pathogen is there, that we're going to pick it up. And so it takes out of the equation a lot of the genetics, whereas with antibody-based testing, that's going to be a little bit more of a factor. What's the host response? Is it a genetic response? Is it an exposure response? Is it epigenetic? Is it, their overall immune health? I mean, it's just a much more challenging puzzle.
Mm-hmm. Yeah, that makes sense. Another question, for the urine antigen test, what is the estimated sensitivity for chronic Lyme patients?
So that's a fantastic question. And I think it's one of the things that we're going to continue to study. We've done work in chronic patients. We found that, it's useful in diagnosis. How it actually performs in terms of across all the different types of Lyme is something that we want to consider to study more and really understand as we go forward. It's difficult to say because at least when you study acute patients, right, you have rash presentation, you have antibody presentation over time, and there's different ways to qualify that. In the chronic cases, if you don't have a positive result, like somebody like my husband, it's really difficult to say who's infected and who's not. And so doing those studies is challenging, but we're continuing, and we've got a grant writer on board that we want to continue to do research. We have a lot of research collaborators that are looking at, the impact of these different pathogens on complex chronic disease states. But complex chronic Lyme is, there's neurological, there's rheumatological with your joints, there's cardiac, and really understanding what that looks like over the course is difficult. What I can say is we've seen it in all of those types of cases, and we find that doctors find it a really useful tool to say, when is Lyme at the forefront of this person's case? And when is it maybe something else? Like we've had a lot of patients that come in and that we talk with providers and they're convinced that it's Lyme because they've had Lyme in the past. And, and it's one of those things that's like, I know it's the Lyme, and then we do testing and then Lyme is negative, but the Bartonella is positive. And now as we've just introduced Babesia testing, and we're getting a lot of Babesia, positives at these really low abundance levels, and, that are not being diagnosed by other methods. And so I think understanding what's front and center and what's causing the issues is really important. And that's why I think direct detection is that key piece.
I agree. And as a patient that's had this now for 10 years, because I have Babesia, Bartonella, and Lyme and other things. It was the Lyme actually that peeled away first. And then it ended up being determined that a lot of my symptoms were Bartonella related. So they have to be treated sometimes completely differently. And I think that's something just so many people aren't aware of is the way you're treating Lyme, you might not treat Bartonella or babesiosis. So you really need to know what's going on in your system.
I couldn't agree more. I mean, if you look at those three pathogens, the treatment protocols are different. And so understanding which one you have, you can, as Dr. Breichwart at NC State says, it's like you can drown Bartonella in doxycycline and it's not going to make a difference. And so it's really important to understand what you have on board so you can make sure that you're addressing the right things.
Yeah, all comes back to accurate testing.
Exactly.
Someone asked if you can explain how Galaxy testing differs from some of the other more accurate testing on the market.
Yeah. I would say that a lot of even in the specialty space, a lot of the, techniques that have been used are still different ways of doing antibody-based testing, right? You've got, looking at different bands, looking at different ways to call a positive result, doing multiplexing. They're still at the core antibody-based testing. And I think there's a lot of other there's not a lot. There's some labs that offer direct detection, but they don't necessarily ever pop up as positive because they're not solving some of these key sensitivity issues. And so what drew me to Galaxy was really going full at how do we make PCR work? How do we solve this problem? And also realizing that it's not a one size fits all answer. Whereas like digital PCR is fantastic for Bartonella and Babesia, it's not the best solution for Lyme disease. And so that takes a different approach. And so really understanding what the toolkit is to make sure that we have accurate detection across the board is, I think, that deep understanding of the pathogens, because the history of the company was really in research, and really understand. I mean, our founders have over 400 peer-reviewed publications, and so that's what drew me to the company. It's like I want to be where the science is. I want to solve this problem so that people don't have to go through the same hell, frankly, that my family went through and that my husband went through. And so that's, I think, what sets us apart. I think we also, as a lab, we like to be transparent. Here's how we do our testing. Here's what we do. We like to publish and share our methodologies. I think that science-based approach is really critical to advance the space.
Yeah, it's the company's rooted in knowledge, the testing's rooted in knowledge, and when I think about things like Lyme and other tick-borne conditions, it's like people can't keep using the same things and the same methods they were using before because I really feel like it's a smart bug, and it just behaves differently than so many other illnesses and diseases. I'll give it a few more minutes if anybody else has any other questions. Unfortunately, we cannot answer any questions related to treatment. That's not, I love talking about it, but it's just not the topic of the webinar. So I'm sorry to anybody who's asked a treatment related question. But I would recommend that you go and you look at the bank of webinars on the Project Lyme website, which is projectlyme.org, because we do have a lot of treatment webinars available and it might answer your questions. Do you think in the future, Nicole, and this might be a silly question, but I'm just curious, the same way that you have the BBB test, that you'll be able to do that with other tick-borne illnesses, or that will kind of be the new standard? Because also as a patient, the fact that you can do all three of those in one test versus going and having 20 vials of blood taken is very appealing.
Yes, yeah, no, that's absolutely in our plan. So, and also it's already been shown in the research setting. So our collaborators over at NC State have already kind of included, anaplasma, Ehrlichia, rickettsia, even like mycoplasma, those are all methodologies that, or all pathogens that we can end up multiplexing in the same test. So we'll get there. I think, when you go and you put it in a clinical lab setting, we want to make sure that our validations and the testing that we run is top notch. And so our focus was let's get the BBB, which are the top three, and frankly the hardest. If you go back to that slide about Ehrlichia and anaplasma and so forth, those are easier to detect with a current method. But I still think there's value in putting it in the panel because, like you said, if I have to send this off to Galaxy and this off to LabCorp and this off, then it gets expensive and it gets to be, problematic. And so I think there's value in having that panel. And what I would like to have, and where we'll go in the future, is just a panel where, you get bit by something. It's not just a test for Lyme disease, but you can, do a urine-based sample, see if you have Lyme, and then do this blood-based co-infection panel and see if you picked up anything else from that tick, or exposure. Again, not just ticks, fleas, cats, cats are vectors for Bartonella. And so, a lot of people say, well, I've never been bit by a tick. And I'm like, well, do you have a cat? Because cats have really high levels of Bartonella and we all love our pets, but it's an exposure risk that people need to be aware of.
Yes,
And I can't tell you how many stories that we've heard about people getting sick after they adopted an animal. And so it's just one of those things that people need to be aware of.
absolutely. I agree with you. Would you mind, Nicole? I do know that you said it earlier, but would you mind just repeating if people have questions where they can go to on the Galaxy website to submit those questions to get connected, to the right individuals and get answers?
Yeah. Yeah. So our website is great and set up where providers can go. We also have information for patients there that can be helpful. On our website, you'll see there's contact@galaxydx.com. So if people or have questions or patients have, issues that they want to get further clarity on, that's a great resource. We also have, social media on Instagram, Facebook, LinkedIn, those are resources where we're constantly publishing kind of the latest in our test offerings, the latest in the research, the latest key findings that people should be aware of. And so I would point people towards that. And then I would also, just as another plug for that Center for Lyme Action, the State of Lyme Disease Research, I think one of the reasons that I agreed to work on that project with the Center for Lyme Action is because it was kind of what I wished I had when I was a caregiver, right? Like a single resource to go and understand what the state of Lyme disease research is. What does the science say? And what is, I was so confused when I was researching between, the CDC says this and that, and the research says this. And then I would read the research papers, and one research paper would say this and one research paper would say that. And so the CLA paper was really just a way of putting the information together. Here's where we really are in the state of science. And here's where we need more research and why that research should get funded, which is, the goal was to give it to congressional staffers and get more funding. And so, but it's a great resource for patients. And then also I've encouraged people at ILADS and patients to give it to your doctor. Like if you have a doctor that's not very Lyme literate, it's a good resource for them to get up, to speed and to understand that this is not a made up disease. This is not something that, is in your head. There's real science that shows these pathogens persist. They're linked to complex neurological conditions, cardiac conditions, rheumatologic conditions, and it's something that needs to be taken seriously.
That's a phenomenal idea, giving that paper to your clinician if you need resources. It's a very good idea. So for anybody listening live or to the replay at a later date, if you want more information about Galaxy or if you want to read some of their research, some of their published research, you can go to galaxydx.com. If you are looking for other educational resources, information on the signs and symptoms of Lyme, or other webinars, you can go to projectlyme.org, and there is a plethora of information there. Nicole, thank you so much for doing this with us. You are an amazing human. We're lucky that you shared your knowledge, and
Oh,
um, we'll see you
great.
later.
Thank you for having me and for all that Project Lyme does to raise awareness and education and, the research and so forth, because it's what this community needs.
We're all in it together.
That's
We've
right.
got great. Have a good night, guys. Bye.